All right. So I'm going to address for you how ASHA is able to support implementation and dissemination research, but also provoke and ask you to consider what more can be done. And after Howard and I speak, Patty Prelock is going to address that more and to really encourage you all to tell us what you think. In full disclosure, I am an employee of ASHA, and I have a number of non-financial involvements with various agencies and groups that are related to these sorts of efforts. I'd like to start by just saying that CSD professionals and really healthcare and educational professionals and other disciplines work very hard to deliver skilled and thoughtful care. But it is difficult for providers to consume, translate, adopt, and adapt scientific evidence when most of the research is conducted with ideal patients in contexts that may not match the populations, constraints, and cultures in their own setting. Dissemination and implementation science can light the way, helping to improve the adoptability and applicability of effective interventions to help providers deliver evidence-based practices that can be adapted to their patients and care delivery settings in ways that maintain the active ingredients and integrity of the intervention. There are actually five things that I have thought about throughout these past couple of days of things that are needs, things that we need to do. And in some respects, ASHA is already doing some of these things. Of course, we are looking for ways to spread that and scale up that and do that better. So we need to consider and plan for implementation early on and often throughout the evolution of an intervention. I think that point has been really made directly and indirectly several times. And this, of course, would necessitate that provider perspectives, as well as patient and other stakeholder perspectives, be solicited and incorporated where appropriate. And Dr. Mittman talked about this as being a primary principle of PCORI, and I think that it is one that we need to consider, particularly in terms of gaining provider perspectives when we are developing an intervention. ASHA has a few things that might help you with that. One is our CLARK program, which is an online social community. It stands for clinicians and researchers collaborating to exchange ideas, to share information about research interests and projects, to help researchers identify clinical colleagues and recruit participants, and importantly, to help clinicians provide input about clinical research questions important to their practice. We've just launched this this year in January. We already have about 500 people, pretty much a good split between researchers and clinicians who are talking about clinical research issues and providing a good bidirectionality and exchange of thoughts as well as possibly resources and collaboration. So if you haven't heard of Clark, just go onto the website, the ASHA website, and search for it, and please consider signing up for this social community. We also, of course, have many special interest groups also with their own online communities. And I think these are really ripe to be used to ask questions. I've got this intervention. Click here and see it. Tell me, do you think you could do this in your setting? And if not, why not? And that might just be some low-hanging fruit to help to improve implementation down the line. I think we also need to help providers consume and translate research evidence in an efficient manner, and this has long been known. ASHA fields surveys frequently, and hopefully you all respond to them because we really need your input. And for the past 3 fieldings of our knowledge, attitudes, and practices surveys, Time has been stated as the number one reason why clinicians are having difficulty adopting and perhaps adapting evidence-based practices. They just don't have the time to go through all of the literature and figure out what's meaningful for them and how it works for them, and it's very time-consuming. They also have stated that there's questionable applicability of the evidence to providers' settings and to their patients, and lists this as the number 2 barrier. So, of course, as we know, much of our research is done with ideal patients in ideal settings, and they're not always, the clinicians are not always seeing exactly how that applies to them. I would also argue, though this is not supported by survey data, that there is a lack of top-down mandates to adopt evidence-based practice, and I think this is a likely deterrent. We're all busy, we're all doing as much as we can, at least we think we are, and unless really there's some kind of hammer there, you know, a carrot and a stick sort of metaphor, I think it's hard for people to really decide they're going to put a lot of effort into changing something that they've been doing and that's been working for many years. We have at ASHA developed our practice portal as a major effort towards knowledge translation. And in this practice portal, what we do is incorporate evidence-based systematic reviews, evidence-based guidelines developed by ASHA, developed by ANCDS, developed by others that meet our quality criteria. And we translate that into evidence maps, and then it shows up on the portal, which is a mobile-ready application. And if you go to the portal, which I really would encourage you all to do, it's a marvelous teaching tool as well as a clinical and learning tool, you will find that there are descriptions of different disorders, incidence prevalence information, information about signs and symptoms, assessment, treatment, and many resources. And also there are supported by the evidence maps that the National Center, ASHA's National Center for Evidence-Based Practice produces. And these are maps that you can click through on a particular spot. For example, if you were interested in, well, I'll just go to script training here because Leora Cherny, who's in our audience, is a primary investigator and creator of that. And you can click there and you can see what the guidelines, systematic reviews, consensus guidelines, and client and patient caregiver perspectives are on using script training. And this is going to look very similarly for assessment as well. We bring evidence highlights and expert opinions. We have strict criteria for what can qualify as an evidence highlight, as well as expert opinions. So we're trying to distill out of stacks and stacks of articles, the kernels, different meaning of the word kernels, but I'm primed for that word now, of what they can apply to their patients in their settings. We've had great visibility and use of the portal. This is a graph just to show you that the way we used to do this sort of knowledge translation was through these family of policy documents. They would typically take years to develop and they would quickly be out of date. And they were approved by the board of directors, so there was no sense that we could go in and tweak a thing here or two because it needed that very formal approval. These practice portal sites are meant to be updated frequently and in fact are. And you can see that they're getting a lot of use. Here is just a quick list of some of the topics. And by the time we are fully developed at the beginning, we hope, of 2018, there will be over 100 topics that are in the portal. So this is a tremendous resource. It is available to members and to non-members, and we would really appreciate if you would spread the word about this resource. We think it's going to greatly help with knowledge translation. A third need is the need to cultivate, nurture, and support scientists to forge new paths to improve translation, implementation, and adoption of evidence-based practices. This is the knowledge generation piece that is crucial and that the association supports along with some of our partners like NIDCD. We have grant writing, mentoring, and research education programs, and here's just to mention a few. Pathways and Lessons for Success are supported and co-sponsored by NIDCD. Pathways aims to assist very early career clinical scientists in developing strong foundations for independent research careers. Lessons for Success supports individuals who have already submitted a grant, whether it got funded or not, but they have experience with grant writing to come and learn more about grant writing, development, and management of successful programs of research and other professional research competencies. And then we have our Clinical Practice Research Institute, which is really aimed more at mid-career folks, and I think we have Liza Feinstack and Sonia Pruitt and Carrie Ebert in the audience that were just recently at our Clinical Practice Research Institute. And CPRE basically aims to accelerate the generation of research to support evidence-based practice and implementation science. And I just sort of wrote implementation science. We actually haven't had anybody come to do implementation science there, but you know, typing is easy. And should you want to come to CPRE and get support, we will find good mentors or consultants for you to do that. And I would like to say that across all of these three programs, it's been a very interdisciplinary effort, and we've had great scientists from other disciplines come to help support our researchers. All right, just a little bragging on this very quickly. Lessons for Success, which I see Sharon Moss way in the back. When she was at ASHA, she started years and years ago along with the Research and Scientific Affairs Committee. And Susan Lott, who's in the audience over there, is now the ex officio to that committee that supports the Lessons for Success program. And it has succeeded. On our renewal, we were able to look back from 5 to 8 years for different statistics about how well the participants have done. The success rate overall was 39% for all NIH applications, which is good. I would say good. The overall success rate was 94% across all funding mechanisms, including intramural and foundation and others. The proportion of protégés receiving NIDCD grants was considerably higher than the general NIDCD applicant pool, as you can see. So these programs are working, and I think they can be expanded to include these areas of implementation, dissemination, research. We also have a grant review and reviewer training program that we partner with the ASHA Foundation, and this brings experienced and junior grant reviewers together to review some of the ASHA grant applications for these various mechanisms, and it aims to prepare junior reviewers to effectively serve as reviewers at the federal level. It's a very important program because not only are we trying to do the business of helping the foundation to select the best grants for funding, but we're also trying to influence the review culture. This is a tough culture to influence, but what we're trying to do is to prepare these junior reviewers to champion the best grants, to not sink the best grants, and to know what they're looking for and how to communicate on a review panel. And I think education can be incorporated about the importance of these emerging areas of science. Fourth, I think we need to better support dissemination and knowledge translation. This necessitates that journals, editors, and reviewers support publications of all phases of intervention research and implementation science. And I think that I will defer to Dr. Prelock, who will talk a little bit more about the culture of reviewing in the ASHA journals and some of the things that have been concerning many of us as we're trying so hard to grow the evidence base and now the implementation science base, but there isn't always the warm fuzzies that we would like when people are submitting early phase research, for example. I would like to pitch, however, that we have a wonderful function that is not being used very well, and that is electronic supplementary material. So the ASHA journals, since we went online only, has supported authors to submit video, 60-page manualizations of your treatment. We will publish this as electronic supplementary material, which, if you think about it, might really go very far to helping clinicians to use evidence-based practices. But we get very, very few of these submissions. So please think about your next submission to an ASHA journal, and actually many journals support this function, and think about what you can submit that might help clinicians to better understand the treatment or the assessment technique or whatever it is that you're describing. Obviously, if a picture's worth 1,000 words, a video must be worth millions, right? So it's great. Please do this. Tell others about it. ASHA journals are also improving. We're very excited. January this year, we moved to a new platform supported by Silverchair. You can go to pubs.asha.org. Check us out. We developed a semantic ontology for CSD, which is really more complex than a taxonomy because it shows relationships between terms, and merged with the National Library of Medicine's Cortex taxonomy that supports many of the search mechanisms in publications these days. And of course, it was a wonderful opportunity because there'll be bidirectionality of the ontology we created back to the National Library of Medicine so that, for example, they can better interpret a word like fluency. This is a tough word for people outside our discipline to understand because, of course, it refers to stuttering, it refers to word naming, it refers to the prosody. So there's so much confusion, and what we had to do is to show how fluency in this context meant that when associated with other words, and that's kind of how an ontology is developed. There are now topic collections associated with the journals, so if your interest is in dysarthria, look at the topic collection because there's articles listed there, and also there are related articles that get offered up, much like Amazon. When you type in your search terms, you get the articles you want plus some others. And what's very nice about this is that we have merged the special interest group perspectives publications and the leader publications so that you can get a variety of articles on a particular topic as you search. And again, Dr. Prelock will talk about our ad hoc committee on strategic planning for the journals, which is just getting underway to help improve this even further. Lastly, we need large-scale databases to determine the effects that case mix or patient variables and service delivery factors have on outcomes. And this is something that we haven't really gotten around to talking about much during this conference. But in addition to the need for the phases of intervention research and to consider implementation science early on and to scale up to do implementation science, there's this other player in town that is a really important one, especially in the emerging healthcare landscape. And that is the use of large-scale databases to inform what's working best for whom under which circumstances. It necessitates that data be amassed in centralized repositories so that we have sufficiently powered databases to detect factors that influence outcomes. And these factors could be service delivery treatment factors. They can also be context, circumstance, service delivery factors, as well as patient factors, which clearly all interact to determine outcomes. Clinical registries can be used to predict the rehabilitation potential of patients based on historical data, and which approaches are likely to generate the best outcomes and to sustain continuous quality improvement efforts. ASHA has had for over 15 years our national outcomes measurement system, and we are working very hard to improve this system and expand what it can do to be another avenue, another source of information to guide practice. So clinical practice research basically addresses this idea of what works best for whom under which circumstances. And within each one of these components of this question, there's huge whole programs of research. Okay, so to address all of this as an individual investigator is really quite a lot to take on. And what we really need is everybody working on the parts that they work on and then together to pull it together. But it's very hard across people all over the country with the gaps that might exist to pull all this information together without using a centralized data repository. So ASHA is trying to turn NOMS into a large-scale data set, which it already is, to address this question. This is our focus. Accordingly, there are 4 major data elements that we are developing for NOMS. Case mix factors, we already collect some information about patients, and certainly, but there's a lot more that we could do. We really don't collect much about the services that are delivered other than how many sessions there were, pretty much, whether they were group or individual, and that's kind of about that. We have a really kind of concentrated on this two particular needs to enhance this system. One is to develop a treatment taxonomy, and we are starting with services delivered by SLPs in healthcare, though we intend to spread to other areas. And a treatment taxonomy, which I'll talk more about in a minute very briefly, is needed because you can't even begin to ask what works best for whom if you haven't described the what. And so this is something that we're trying to do in a large-scale data set format. Outcomes are the other piece that we're really focusing on, and we already collect clinician-generated outcomes, the FCMs, the functional communication measures, where you rate how severe or how improved a person is. But we are now looking to incorporate patient reported outcomes as well, and Kathy Yorkston, who is here, is chairing that committee. And of course, in this current zeitgeist, we are looking to determine the value of services, and that cannot be done without estimates of cost. So it's sort of outcomes over cost, and we have some of that information, but we hope to collect more. So the treatment taxonomy group is basically trying to do a lot of what we talked about over the past 2 days, which is to better specify the ingredients, those that are active, those that are inactive, which presumably can be adapted then, and what is essential. And the essential ingredients, at least I would argue at this point in time, are those things that we cannot adapt. Those must be maintained in a treatment. But certainly the inactive ingredients, and then it's arguable whether the active ingredients can be adapted a little. So we are trying to determine what the ingredients are for treatments and to hypothesize a little bit about the mechanism of action underlying that, but those are largely hypothetical, and to better specify the target of intervention as well as the long-term aim of intervention. So you're trying to improve word finding, would be a target, so that conversation and social interaction is better supported, and that's an enablement aim. We are going to approach this as using a facet taxonomy in which we will specify the clinician inputs that are presumably the active ingredients, where the services are delivered, what the dosage intensity is, hypothetical mechanisms of actions, and then to specify both the proximal and distal targets of treatment. So we know what it is that people are trying to change and why they're trying to change it. And we will be using an elaborated ICF coding for that. So the International Classification of Functioning Disability in Health has codes, and they're not completely perfect for our field, but they're pretty good. So we might add a few and be able to use the ICF finally. Yay. Exciting. Okay, so outcomes measurement. Under Kathy's leadership, we have been discussing quite a bit about the constructs to be measured, and we already, through our FCMs, the functional communication measures, kind of get in this zone between impairment and activity limitations, but we don't look very much at participation, and that is really where we're trying to go. And I see Carolyn Baylor sitting right there, and Carolyn has also been very integral to this work. She's developed communication communicative participation outcome measures, and she and Kathy and others are on this committee working with us. So we have looked a little bit at how these constructs can be measured, and as you can see, there's a great need to collect data from patients or from their caregiver or whomever to get really across these areas. Clinicians can talk about process, impairment, and function, but really not appropriately quality of life or participation. And occasionally we luck out and we get some really objective instrumentation measure, but not all that often. Okay, so how can outcomes measurement improve quality and value in healthcare? And I just want to bring your attention to this resource if you're not familiar with the work that the Institute of Medicine has been doing on engineering a learning healthcare system. I would suggest you look at this. This is really kind of a very seminal, important step. They have stated that by 2020 they want 90% of clinical decisions to be supported by accurate, timely, up-to-date clinical information that will reflect the best available evidence and informed personal preference. This will require the development of clinical registries that function as learning systems. They seek the development of learning healthcare systems designed to generate and apply the best evidence for collaborative healthcare choices for each patient and provider, to drive the process of discovery as a natural outgrowth of patient care to ensure innovation, quality, safety, and value in healthcare. And we are trying to fashion our national outcomes measurement system to do this, such that we will be collecting case mix, treatment information on the services delivered, outcomes across the clinician and the patient perspectives, and some cost data. We'll analyze the variation. We will identify sources of superior results and perhaps inferior results. We will translate that knowledge, and we will translate that knowledge in a way that can be provided as point of care guidance, so that if you're seeing a patient, you enter in the case mix information and the areas that you intend to treat, and up comes data that tells you, for this kind of patient with these sorts of goals, these treatments have achieved what sort of outcomes based on clinician and patient perspectives. So you can go, wow, that really high bar there, that must be the treatment I want to use, but you know what? I don't know anything about that treatment. So you can click on that treatment and you can be taken to the practice portal. And in that practice portal, you will be able to learn about that treatment, perhaps see videos of that treatment, be exposed to the research evidence on that treatment, and begin the path of incorporating that new evidence-based practice into your repertoire of treatments. That's the vision. And we see this as being an important and complementary effort to the investigator-initiated intervention research and implementation science that is going on. And lastly, I apologize for the blurriness of this slide, but I just wanted to tell you that in the next generation of NOMS, in addition to having the adult SLP section and the current pre-kindergarten SLP section, we are going to be building out audiology, early interventions, school, as well as K through 12 healthcare databases to provide this sort of service for all of our providers. Thank you.